Hello, everybody. We're talking about early access today. Let me give you a little bit of a caveat. Just because I say early access sometimes can have outcomes be more robust, not necessarily better. I'll just say more robust. You can notice it. It's bigger, it's broader, it's brighter, depending on what we're talking about. Doesn't necessarily mean that you still can't get benefit even if it's later. Okay. So I'm Dr. Virginia. I'm a double board certified psychiatrist and lifestyle medicine provider. So we're talking about early access as it relates to autism because it is Autism Awareness Month. Now, why are we talking about this in particular? Well, let me give you an example of something that I remember being told in medical school. And ever since then, it was huge. It was very eye-opening. In medical school, we were shown two pictures of cousins who both had PKU, phenylketonuria, which is an illness that we actually, it's genetic, and we do test for it with newborns when they're first born. And the first one was a young man, and you could clearly see that he had some different abilities. And you were told that at the time they called it mental retardation, but he had intellectual delay or intellectual disability, an IQ of less than 40. And you were told that he would, obviously not be independent in life, didn't make it past, I think, maybe a third grade education and had some difficulties. Now you got to then see the cousin of this young man who also had PKU, and he was neurotypical, average or above average IQ, at the time was in like middle school or high school, normal height, normal stature, wasn't short for his age. And the difference was diet. That's it, just diet. If you have PKU, phenylketonuria, you cannot have phenylalanine or products that have phenylalanine because they make it very difficult for you to process because you don't have the enzyme that's needed to process phenylalanine. And I was just looking at a label here. And if you look at most of your labels, this one doesn't have it because it's stevia, which is a natural sweetener. If you look at, for example, an Equal or Splenda or the pink label, if you look at them, you're going to see a little piece of that says, for phenylketonurics, this contains phenylalanine. If you look at the back of most of your things that have some type of a processing to them, a cake box, creamer, cereal, whatever, it might say, mostly, especially sodas, it's going to say this, you need to be concerned because if you have phenylketonuria, this contains phenylalanine. Basically, what they're trying to warn you about is that you are not going to be able to achieve your cognitive best if you're exposed to phenylalanine and your body can't break it down, right? It just kind of gums up the system in multiple areas, but especially the brain. It's kind of like if a person has Alzheimer's, dementia, and you have those neurofilaments and tangles in the brain, and that's part of what we think causes cognitive decline with dementia. Something similar with phenylalanine because it just kind of gunks up the system in the brain. So early access, early intervention, night and day difference in phenylketonuria. Because if it's detected as a newborn, then you can tell that parent this child should not have phenylalanine. They need to be on a very restrictive diet for the rest of their lives. And some people dibble and dabble, but they can actually tell you, yeah, I notice when I eat things with phenylalanine, I don't feel as with it. I don't feel as bright. I don't function as well because, yeah, I got extra gunk in and around my brain that shouldn't be there. Okay, so it's like brain fog to the max. How is that similar to autism? Well, even though we don't have one silver bullet, one perfect target, for the information that we do have about autism, if you start certain things when a person is younger, I'm going to give you 3 examples. When you start these things on a younger child, they tend to do better than if you delay and wait for an older child. So I'm going to give you a couple of pleas. It's the call to action that I'm giving for today. Plea number 1, If you are a family member of a loved one and you suspect that they may have autism, please don't stop advocating for that individual. Okay. I will give a little bit of my story and share, but most parents are in denial. Even trained parents are in denial when they're first told that their child may have autism. Okay. Here's the issue. All of us want, for the most part, healthy babies, right? We already prayed about that. Hey, what do you want? What do you want? Do a boy or girl? Oh, I just want healthy. We already had a, a talk about, well, what if you don't get healthy? You get a special child, which has its own benefits. We've talked about that, but it may not be what you were expecting. It may not be what you hope for, what you prayed for. But what you get is very life changing and completely worth it. But what if you could optimize the future for your child? You would, of course, want to do early intervention. So let me tell you a little bit about my story. When my son was born, had some difficulties, but started hitting some milestones later, but over a period of time, he started catching up in certain areas. I distinctly remember the year when he was in preschool and he was counting to 10 in English and Spanish. He was starting to spell words. He knew his alphabet. He knew his alphabet sounds, many of them, many of the phonic sounds. And we were thinking, oh gosh, he's finally catching up from what happened when he went through birth process, first year of his life, all the difficulties that he had. So I'm thinking, oh, great, he's catching up and he's doing well. And I will never forget, around the winter of that year, we must have noticed something that we said, hey, let's take him to a developmental pediatrician. He was already seeing a developmental peds person anyway. But we said, let's reestablish care where we are and take him to a different developmental pediatrician. And I don't know what in my mind at the time, I can't remember what triggered that. What I do remember is that when we took him to see Dr. Conlon, absolutely love Dr. Conlon. Remember, Dr. Conlon said, he used the A word. He said autism. Whew. Went right over my head because that was not what I was thinking. I was thinking about and asking him about other things. Will he catch up with these other milestones, the things that he's still delayed in? Can we catch him up? How can we catch him up? So when he said autism, I was just like, not what we came for. He doesn't have autism. Let's move on. But this was a developmental pediatrician who had done several tests, including, if I'm not mistaken, an ADOS at the time, which is a test that you can use to see if a child does have autism. And I just wasn't ready, but I do distinctly remember this was the winter of the previous year. Now, what did I do? I just kind of sat on that. I remember talking to my husband about it. We both were kind of like, yeah, let's just work on all the other things that we know are going on with our son. And we'll pick back up on that. We'll have him retested in like 6 months. Now, fast forward 6 months later, I was no longer doubting. I was, what do we need to do to treat autism? All right. I had fully accepted the diagnosis. It took me 6 months, but I fully accepted the diagnosis. And then I was just like, what do we do about it? Come on, let's move. You told me a problem. Let's find a solution. Okay. Don't come bringing me no bad news like the whiz. I just need a solution. What's the solution? Okay. Very solution driven. And then when I was told all the things that need to be done, it was like, okay, let's do this. Let's get him into RDI at that time. And then it was like, let's learn about ABA and let's learn about this and learn about that. So even with me, I delayed some diagnosis as it relates to the autism diagnosis and delayed in some of the care that he could have gotten within that 6-month period when he was diagnosed at 3. He was still 3. But rather than 3 years, we're now out to 3.5 years because I was just in denial. You will see a lot of parents that are in denial as it relates to their child when, especially a first child or when there's a gap, because they don't really know what's normal or not normal, what's within the developmental milestone range and what's not. Plus, for us, there were already some delays and some lag. So we just assumed, hey, it's related to some of these other things. But if you are an educator, a teacher, a relative, a neighbor, and you're seeing a delay, it is worth having the frustration, anger, offense of that parent or whoever it is to say, hey, have you considered, or are you, do I have your permission to share something? And I always, always, always share from my perspective. Okay. So I'll talk to you about ways to do that. But advocate for that child, advocate for that person, even if it's an adult. Advocating for a person in high school or college, whatever time you decide that there might be something going on, to advocate at that point in time is the best thing you could possibly do for that person. The younger, there are 3 treatments that we know hands down work better. ABA definitely works better to some extent if it started younger. ABA/RDI, which is relational development intervention. They both tend to do better from a pure therapy perspective if you start younger. Leucovorin, you've heard a lot about that probably within the last year, but it's basically a svelte form of folic acid, right? It's a B vitamin, one of the vitamin Bs, which we need to have most of our processes in our body work the way they need to at an optimal rate, right? It's basically like a cofactor, helps the chemical reaction move faster. Well, there are several articles that have shown that children with autism are often also deficient in the enzyme that's needed to convert regular folate or folic acid to the next substrate down that's going to help progress the chemical reaction. Leucovorin, the form that it's in, kind of bypasses that. So for those on the autism spectrum, it can help with focus and attention and general cognitive development. Okay. It's hard to learn something if you can't focus on it. It's hard to focus on it if you haven't even attended to it, if your thoughts are all over the place. Okay. So from a cognitive standpoint, leucovorin may be very helpful. But again, if you're looking at studies, kids less than 12, definitely less than 8, seem to have the best outcomes. TMS, that's another treatment. It's a treatment that we do within our office. First of all, it depends on which area you're going to. We are very specific and very strategic. Yes, there's an autism protocol that you can use with just about any machine, but the machine that we use specifically for autism allows us to target different areas, right? Because it depends on if I'm targeting frontal lobe for aggression, or if I'm targeting the speech area because I'm trying to stimulate that area, or if I'm targeting another area from a cognitive perspective, okay? So those are all different areas, and we break that down. As you probably guessed, if TMS is used in younger kids, there are better outcomes according to the scientific data that we have available. So those 3 things, some type of behavioral therapy, such as ABA, applied behavioral analysis, or RDI, relational development intervention, leucovorin, and TMS, when you use those 3 things younger, science supports better outcomes. Now, what about my middle school students, my high school students, my college students, or my adult students? The earlier that you diagnose and then start treating, the better. It doesn't matter if you're talking about a 30, 40-year-old adult, and I'll tell you why at each of the different stages. Let's say you don't figure it out until middle or teenage years, and it's like, cat's out of the bag, no point. Well, do you think that that child might go on to higher education? Okay. Or may eventually be employed. Well, then you want to start the treatment, whatever age they are. You know, my son's 16. We just started one new treatment on him 2 years ago. So at 14, and another one this year, right before his 16th birthday. So at 15, right? Maybe not the optimal age, but we still saw a difference. We still saw positive behavior acclimation, positive behavior adoption, and then just positive behavior in general. We saw that with these 2 different treatments that the science says have the best impact at significantly younger ages. So even if it is later in life, you still want to do it, because a child that didn't have treatment may not be a great candidate for certain programming in high school or employment education or Project Search or certain DDA programs, or they might not be the best fit for college. But after they get certain treatments, who knows? You may open up an entire world for them. Another thing is, I've had people say, oh, well, I'm higher functioning autism, or I think I'm probably going to be level 1 autism. There's no point in me getting diagnosed now. I'm in high school. No, wrong. Because if you have a 504, an IEP based on a diagnosis when you're still in school, when it's time for things like accommodations in college, accommodations for work, that's important. Same thing if you are now in college and you're thinking, hey, it would be a waste of time for me to get tested. Do you think you're ever going to be in a relationship, a social relationship at any point in your life? You're in your 30s, 40s, and 50s. It's a waste of time. Are you going to be in any type of social interaction or social relationship, either through your work, your play, or your home life? Then it behooves you to get the testing, right? You don't want to label. We like to listen without labels because labels are it's just a common language so that everybody's on the same page. When I say autism, everybody kind of understands what I'm talking about, or at least they think they understand what I'm talking about, right? If I say level 1 autism, they get that versus level 3 autism. They get that, right? People that are in the know, whether it's socially know you or your providers, once they know you, it makes sense if you say that. If you say, oh, yeah, well, this person's level 3 autism. Okay, I understand what they might need. They might need one-to-one. They're probably needing additional supervision. I may have to tailor work for them very specifically. Okay. They may be more prone to behavioral concerns, right? Their behavior may speak more than they do out of their mouth. Okay. Common language. But you can get the quote unquote label or the diagnosis so that there's only one purpose outside of communicating and being on the same lane for me for a diagnosis, and that's resources. Because usually we tailor resources to the specific diagnosis. I'm not going to treat a person with a diagnosis of depression with medicines that I normally use to treat, I don't know, sorry, that's a chime, leukemia. Just throw something out there. We normally wouldn't do that. But if I have the right diagnosis, then I know the right treatment. And then I also know what resources to give to the patient. Go watch this video, go download this app, go start journaling on this topic, right? I'm going to treat grief and depression possibly differently. I'm going to treat treatment-resistant depression differently than the person that comes in my office. They've never been on anything, and this is their first time having difficulties, right? So I want you to think about that. Early access, absolutely best. Please advocate for those who don't necessarily have a diagnosis. Find somebody that will do evaluations. We do evaluations. A lot of people do evaluations. So please don't let that stop you if you go to one person and they're like, oh, well, they wouldn't do the evaluation or they're out 6 months. Okay, keep trying, keep trying, keep trying. All right. Oh, well, we can't do it because that person doesn't accept my insurance. Go to your directory and find somebody that does, or talk to other people. I had someone call literally yesterday, a provider from another clinic called and said, hey, do you do this? Yes, we do. Do you do this evaluation? Yes, we do. Do you take this insurance? No, we don't. But we know someone that does. Consider such and such and such place in Columbia, right? I have no problem sending patients someplace else. I train at Mayo, my husband and I did, and the Mayoism that we really live by is the needs of the patient come first. Why should you come to my clinic and pay out of pocket when this company down the corner takes Aetna and they're in network and we're not? Okay. Only one reason to come to us is if you think we can offer better care, right? If you think we could offer better care and it's worth it to you, then we're happy to have you on board. But otherwise, the needs of the patient comes first. If it's better for you from a financial standpoint to go someplace else, then that's where you go. If it's better for you from a geographic standpoint, you're in Frederick or Cumberland, please don't drive 3 hours to where we are, right? Let's see if we can find somebody for you in Cumberland, or see if we can make sure that we can connect you with someone in this area, or that you've got family or someone in this area that you can stay with us and we can coordinate with you. We've had that. We've had people that live way out in Western areas or other states or on an Eastern Shore that had family that lived in Maryland close to where we were. And we made sure that we were able to see them on like a Thursday and a Saturday for Spravato treatment, for example. Or they stayed here during the week and went home on the weekends. So we were able to do TMS Monday through Friday. Okay. Find a practice that's going to work with you, because there are some that will do that. Okay. So just please don't give up. Continue to advocate and please don't give up. All right. That's all I have for you guys as related to the early access and why things matter and why it makes all the difference. There is a question that I see, and I did want to answer that. I love it when you guys answer questions. I love it even more when the people that ask the questions are folks that I've seen from before, especially when we were doing lots of live streaming back in 2017. And I come in here and there and kind of do popcorn lives. But for the folks that remember for 2017, I used to go live every night at 9-ish, which usually meant somewhere between 8:30 and 9:30 p.m. Monday through Friday. So Eric is asking, what is Asperger's? So I'm glad that you asked. Present day level 1 autism would probably be the equivalent of what we used to call Asperger's. So the DSM, which is kind of like the psychiatry Bible, we are now on the 5th edition, getting ready to go to the 6th edition of the DSM. We're now on the DSM 5 TR, which is text revised. So there was the DSM 1, 2. I don't think there was a text revision of 2. And then there was a DSM 3 text revision, then the DSM 4, the DSM 4 text revision, then the DSM 5, and now we're on the DSM 5 text revision because they come out like once every, I don't know, a little more than 10 years. And in between time, they'll do the text revision for it because it's supposed to, even though it's usually presented and published by the American Psychiatric Association, it's supposed to be inclusive of mental illness throughout the world. And it has statistics, not only for the US, but sometimes it will have statistics and information from other places around the globe. It also will include diagnoses of things that aren't necessarily common here in the US, but it may be common in another country. So even though it's published by the US, it tries to be global when it can. So based on that, you'll see these multiple revisions and you will see these multiple text revisions of the revision. So in a previous iteration of the DSM, there was autism, and within the autism, there was Asperger's, there was there was pervasive development disorder. There was basically the equivalent of a lot of NOS. NOS is not otherwise specified. And there was a lot of ambiguity. So when they came out with the DSM-5, basically, and DSM-5 TR, they basically said, you know what, we're just going to call it autism and do level 1, 2, and 3. And basically that indicates the ability of the person to function. Like there's a general autism with 3 categories, right? There's very restrictive interests, difficulties with social communication, and there's usually behavioral difficulties, behavioral restrictions and such. So from that general category of autism, then they said, well, they've got these symptoms or concerns, and on top of that, these are the levels of functioning. Level 1 doesn't need as much supervision. They're more verbal. They can communicate with speech, or they're more verbal using some type of a handheld device than level 2, which is moderate, or then level 3, which is severe, where the communication, there's significant communication difficulties. The person may need 24/7 observation or supervision. Okay. And sometimes one-to-one is needed. Asperger's, as I said, has gone away. There's no longer Asperger's. So if a person says, yeah, I'm Asperger's or I'm an ASP, that basically meant that they were diagnosed at some point during the iteration between DSM-4 and before DSM-5. Okay. That also means that they may have to be retested to qualify autism diagnosis. That also meant that there were some people that were diagnosed as Asperger's, which some people used to call high functioning autism, that no longer qualified for a diagnosis of autism after DSM-5 came into being. So that can be a good thing, and that can be a not good thing. It just depends on the person. I've known some people that say, hey, I no longer qualify for a diagnosis of autism, and they're ecstatic about it because it's like, hey, no longer have that label, woohoo, in remission, if you want to say, or just don't have the diagnosis at all. Where some other folks might be a little bit put out because they might have needed those additional supports, and now it looks like they don't need support at all because they don't qualify for the 3 basic areas. So let's say you qualify by 2 of those areas. You don't have all 1, 2, and 3. Well, I can't even diagnose you with level 1 if you don't have all 3 areas. You need to have all 3, plus it can't be accounted for by something else, or not better diagnosed by something else. And then I'm classifying you in the level 1, 2, or 3. So if you don't have all of that, then you may not have that diagnosis of Asperger's anymore. Which, let's say you had Asperger's and you were getting accommodations, that can impact you. And let's say your accommodations were able to allow you to live independently and work independently, be gainfully employed, have a separate income. Now you don't qualify for those accommodations and other things that help you with that. That's a big deal. So that was a big deal when DSM-5 first came out. And then, like I said, in TR, they kind of clarified a couple things, but it didn't change the major change that happened from the switch from DSM-4 to 5. Okay, so I hope that answered your question, Erica. Okay, so this is the longest I have gone in talking in a very long time. It's been 25 minutes. We will not go to 26. You guys, thank you so much. You guys have a very blessed day on purpose. Have a wonderful, have a very blessed day on purpose. Have a wonderful weekend. Clearly, I'm tongue-tied and tired. And for you over